depression rate is very high among the people living with HIV. Almost 80% of people who need the services are not getting it.
When we got in, then we realized there are broader system issues to also address. One of the things that you're hearing is like, oh, we need to order mental health commodities, but we don't know how many to order and we don't know which ones to order. So we wanted to make sure that we're updating. The document is called the Essentials Medicines List, which we want to make sure that it's updated and in line with the treatment guidelines or the standard treatment guidelines are talking about in terms of how do we address mental health disorders, so that we make sure that even all the furthest, remotest facilities will have access to some of those commodities.
Welcome two very special guests to this particular edition of the podcast. We have Esther Mandara, who is the country director of the Clinton Health Access Initiative, or CHI. And then we have the senior associate mental health, Ref Damane. And the two of them today are going to be speaking about the mental health program that CHI has put together in Lesotho. So, Esther, very warm welcome to you. Lovely to have you with us. And I think you're speaking to us on your leave, so that's even kinder of you, and we really appreciate that.
Oh, thank you very much, Chris. And it's my pleasure as well to be a part of the podcast. Yeah.
Oh, that's very good.
Thank you.
Yeah. And Ref, hi, good to see you again. And you're speaking to us from Lesotho, from the CHI office, I believe. Yeah.
Yes. Thanks for having me, Chris. Yes, I am in Lesotho now.
It's a pleasure, a real pleasure. So why don't we jump in, Esther, with a little description of what CHI does, because not all of our listeners will know that, and especially what you do in Lesotho. And then we'll come to the more specialized area of mental health in a minute.
All right. Thank you very much, Chris. And as you have clearly pronounced it as CHI, but in a full name, it's Clinton Health Access Initiative, which was founded by the former president of the US, President Clinton, with Ira Magaziner. And it was founded in 2002 with the overall mission of saving lives and reduce the burden of disease for middle and low income countries. When it was founded, basically to support the millions of people who were dying from HIV. And during that time, it was called Clinton HIV AIDS Initiative. So that's where the name CHI came from. At that time, many people, as you know, many people were dying from HIV and AIDS, and the treatment was available in the developed countries, but it was very expensive in the lower income countries. So when the CHI was founded, it was the main reason was how can we reduce the price of medicine, of the medication, to also support the low income countries, and also to be so that we reduce HIV deaths in the low-income countries. Yes. So that was the main reason. So basically, our main work when we started it was negotiating prices of the ARVs. And CHI was working closely with the manufacturers, as well as our main partners in the countries that we work is the government. We are currently in 33 countries. But almost 70 plus, even more than 70 countries are getting access to the negotiated prices. But where we have offices, we are in 33 countries. So we call it the CHI's way of approach, where we work with the government. Government is our main partner. We work with them, and then we make sure that there's sustainability. Sustainability is key in terms of our programming. So a number of countries' governments approached CHI, and we saw that we can use the same approach into other disease areas. So in 2010, CHI expanded to new program areas from including other disease areas from HIV. We moved to malaria, treating and preventing malaria. We moved to tuberculosis. And then a couple of years later, we also moved to hepatitis, cancer, and also rollout of the life-saving vaccines And also we have expanded to include maternal and newborn mortality with the overall mission of saving lives. So in that case, then we changed our name from Clinton HIV/AIDS Initiative to Clinton Health Access Initiative, because we are now implementing a number of programs.
Sure. Thank you for doing a fantastic job in describing both what CHI was and what it is now.
Yeah.
That's great. Clinton Health Access Initiative, as you rightly say.
Yeah.
And also how you've brought it to our understanding of what you're doing in Lesotho. So now what I wanted to ask you, Esther, before we go to Ref, is why did you decide to introduce a mental health program? What was the kind of compelling reason that made you want to do that?
Yeah. So, I just realized now I didn't mention mental health, the amount of programs that we are
No, it's good.
implementing.
It's good because it gave me the chance to ask you. I thought you did it on
Yeah.
purpose.
Yes. Okay. So what really pushed us, as I mentioned earlier, Lesotho has the second highest prevalence in the country. And looking at the data, we see that depression rate is very high among the people living with HIV,
Right.
especially in Lesotho. We are looking at 29%. And we have looking at the data, which is not that good, but it just gives us some ideas that almost 80% of people who need the services are not getting it. So we saw that it's critical to really make sure that how do we support using, as I've mentioned earlier, we have been supporting the government. With government, we have been working with the government of Lesotho. But then how can we also address the mental health issues? And we know that in the country, since then, we are talking of 2 decades ago, a lot has been done, and there have been improvements as far as the HIV care and treatment is concerned. So, but then because of this unaddressed issue, if I may call it, we saw that it's going to threaten the progress that has been made so far by the country as far as the HIV response is concerned. So we thought that, okay, how can we address this? Because we know that when you read the information and the data, it shows that people living with HIV are twice as much more likely to experience depression and mental health problems than people who are not HIV positive.
Okay.
And also, given that they are under the medication, because it's a life-saving medication and they have to take it during the lifetime, they're also twice likely to have poor adherence, because if they have the mental health problem, then it means that they will not adhere to the medication.
Okay.
Right?
Okay.
So we saw that it's very, very important. And on the other side, on the flip side, we know that common mental health disorders are not likely, probably I can say they are at a very high risk of acquiring HIV. And looking at the data, they're talking about 5 to 10 times than people who are okay, if I may say that. So when looking at this data, we saw that it's very critical on how can we integrate mental health care and treatment into the HIV program, because HIV program is up and running and it's doing work and it has achieved 90-90-90 UNAIDS target. But then with this, if mental health issues are not addressed, then we might reverse the gains that we have made for the past 20 plus years. So that's what really moved us to say, okay, how can we use the existing systems to also integrate the mental health program into the HIV programming?
That's
because when you look at the mental health, in Lesotho, there is only one inpatient mental health institution.
Right.
In terms of the outpatients, the services are provided under the mental observation treatment units, MOUTs, which every district has. In Lesotho, there are 10 districts, and the population of Lesotho is just 2 million people. But then with only one institution, specialized institution, and when you look at the HR, it's also a challenge. There is only one psychiatrist, if I may call. There's only one professional psychiatric for 100,000 people. So when you look at this data, we saw that we need to do something in order to address this. Yeah. So that's
Okay,
where we came from and decided to come up with a mental health program.
great. And that's when you went and found Ref.
Yeah, exactly.
I mean, it was through a process, of course, but that's where we can bring him in. Ref, you're very welcome to the podcast, and it's lovely to have you with us alongside Esther. So we've got a very good idea now, a pretty good idea of CHAI. We've got a very good idea of why Esther felt it was important to bring the mental health program into the wider HIV and AIDS program that she's described. So, and Ref, you and I have talked before. We had a chat before this podcast recording, and I came to understand that you came from a background, which was very much related to public health and mental health. So that's so interesting from my point of view. But why don't you jump straight in, Ref, and start to tell us, what you found when you got into the role, and how you're developing the role now and the work. So that we get an understanding, because this is not a mature program, this is a beginning program. You're in the early stages of it. Esther has set the scene, and so now we are going to kind of walk alongside you as you help us to see how you've developed it. Over to you, sir.
Thank you so much, Chris. Yeah, I think that's a very good summary of what we've been doing. Esther rightly said, we saw quite a lot of gaps and challenges, despite the fact that there is a very strong research base in terms of what can actually work here in lower middle income countries where there are challenges with access, so the program was really targeted towards making sure that the WHO has already developed the MHGAP, the mental health gap action treatment, which is based on the idea that you can train non-specialized healthcare providers so that they're able to screen, assess, and manage people that are coming in with common mental health disorders, right? And so for us, that was sort of like the beginning of our design. The thinking was that, well, we need to make sure that we go in and try to plug in that gap by providing this training and this capacity building in 2 other districts. We're working in only 2 other districts with this program. But when we started, really what we wanted to do was also ascertain, well, what's really the burden like? What are some of the challenges that patients, especially people that are living with HIV, what are they reporting to us, or what are they saying in terms of how mental health is affecting them? Especially since, as Esther was saying, right, Lesotho has that good story of we've been able to meet the UNAIDS target, the 2020 ones, and we're on track to meet the 2025 ones. But we're also still seeing all these mortalities that's HIV related. And for us, the hypothesis has always been, well, we need to be able to close the mental health gap in order to make sure that we are addressing this challenge more holistically. And so when we started, we did that prevalence study to assess what are the rates of depression and anxiety among people that are living with HIV that are coming into the facilities. And we were able to get quite a lot of the times, people were really, really appreciative of the study. It's something that's coming into them and they're like saying, well, I can talk about this as part of my HIV treatment. And it's like, well, sure, you are meant to talk about some of those things. So you were getting a lot of appreciation of people that are now seeing how this bi-directional link between physical health, a condition that they have, a chronic condition, and mental health actually kind of like interlink. And so that was something that we were seeing a lot of appreciation for. And also, we're also obviously seeing there is high prevalence amongst people that are living with HIV. And now how can we better serve them and better make sure that healthcare workers are capacitated to address some of those challenges that they're facing so that we're meeting the physical health outcomes that we want as a country in HIV, but we are also addressing the mental health gap that we're seeing and that's coming in between. And that's just kind of like from the HIV perspective, but we're also seeing that there is an even broader mental health needs amongst the general population. So, well, why don't we leverage the resources that we have in HIV to make sure that we're expanding that access to the general population as well. So that's kind of been where we are. We've already done quite a lot.
Sorry, Ref. Could I just jump in with a quick question on the So you have obviously, you were looking mostly for common mental health disorders. That's the set of assumptions that you started to work on.
Yes, correct.
Yeah. And did you find much serious mental health disorders? You know, for example, schizophrenia or bipolar affective disorder. Did those samples come up, or didn't they really get picked up because of the way you were doing the work?
Well, the way the study was designed was really more focused on just those two conditions. But we were, or anecdotally, and obviously when you go to the facilities, you will see what's being reported as well. There is schizophrenia, psychosis, bipolar disorder, epilepsy to a certain extent. You get those. It's just that for us, the target was, that's why I was saying we were using the infrastructure to address common mental health disorders, but also making sure that people are capacitated to also address some of those major mental health disorders. So as you know, the MH gap does address several of the mental health conditions that we know, including psychosis, schizophrenia, and some of the more serious ones like bipolar disorder. So as we are now going in, we've now been able to train and capacitate the healthcare workers in these two districts. We're also making sure that they're not leaving behind the other conditions, that they're still kind of focusing on all the other conditions that are within that guideline so that it helps them in their day-to-day job as well. So that people don't always have to come to Moshomi, which is in Maseru and quite far away from other remote districts of the country.
Right. So thank you for updating us as to what you found when you came into the role, into the program, started the program. And you've made a quick reference to training, which just in your last couple of sentences. So what would be really helpful, I think, now would be for you to just describe in programmatic terms what it is that you have been doing or what you intend to do. So you mentioned training. That's obviously one of the programmatic issues. Maybe you could tell us, you know, how things started, even if it was small to begin with, you know, we're not here to judge the size of the program. We're here to hear about how it started and how it's going forward. You know, that's the thing. Yeah, please do.
Yeah, okay. So the details are on that, right? So for us, I think as Esther was saying, we've been addressing, initially we conceived it as we'll just be addressing this for just the people that are living with HIV. But I think when we got in, then we realized there are broader system issues to also address. We started like in the beginning of the year, which is in January. And so when we started, we're now looking at, well, how do we make sure that supply is actually secured and focusing and quantification can be done well as well. So we've also been working on addressing that side of the equation to make sure that, because one of the things that you're hearing is like, oh, we need to order mental health commodities, but we don't know how many to order and we don't know which ones to order. So we wanted to make sure that we're updating, the document is called the Essentials Medicines List, which we want to make sure that it's updated and in line with what the treatment guidelines or the standard treatment guidelines are talking about in terms of how do we address mental health disorders, so that we make sure that even all the furthest, remotest facilities will have access to some of those commodities. So we started there. We started on working on that work stream as well. We were also working on making sure that data is available. As you might recall, Esther was saying, you know, there's very limited data pieces here and there. Most of it is anecdotal, but we wanted to make sure that this data, as people are being seen into the program and coming into the facilities and being offered the services, they are being captured properly within either the registry or the electronic systems that are available as well. That's another piece of work that we've sort of been doing. And then obviously the service delivery component of the program was now making sure that healthcare workers are capacitated. We want to make sure that they're able to screen patients. And so what the country adopted is the PHQ-9, the screening tools, the JD7, the PTSD5, the audit for alcohol and substance abuse. So it's a couple of those diagnostic tools that are also coming in to help healthcare workers also be able to screen and assess patients when they're coming in. So we went and made sure that they're translated into the local language, Lesotho. And then obviously now we've validated their use to make sure that the translations is actually working for them. You do take the ethic approach, but then you want to make sure that even the healthcare workers and even the other people, the lay cadres, can be able to read this and make sure they administer it properly. So then we did that at the beginning. And then we were able to, after all of those things, then we set up the training for the healthcare workers to say, okay, we've done all of this things within the ecosystem. Now we want you to be able to go through the MHGAP modules, make sure you're all capacitated and then understand what each of the algorithms in terms of what the MHGAP says follows, so that when you are able to go back into your facilities, you'd be able to address this. And obviously that also means now we need to be able to continually sort of like routinely supervise this trained healthcare workers to make sure that they are picking up and there is uptake in terms of like services provided, but also even for them in terms of skills development and capacity and competency, they're able to service the patients that they see day to day. That's kind of like the sort of broad, and now obviously we want to make sure that the country is able to sustainably scale up this program across all the other districts as well. And so that level of advocacy and resource mobilization is the next step in what the program is seeking to achieve.
Great, thank you for that, Ref. How have the staff in the first two districts, in other words, in your pilot districts or your key districts, how did they take to having to work in the field of mental health, as well as, because, if I come along and I'm a specialist and I want to specialize in HIV and AIDS, and then someone called Ref comes in and says, no, you've also got to deal with, depression. I might say, well, I'm sorry, but that's not my job. How did you get around that? How did you talk it through? What were the reactions?
I mean, I think you sort of hit it on the nail, right? Because when we started, people would say, "Oh, you're bringing in psych. Oh, I don't really like psych." I think that kind of speaks to how mental health is generally perceived, not just even by communities, but also even by healthcare workers themselves, right? There's that hesitance in terms of like dealing with mental health. But surprisingly, like when we were going through, and now we're like, well, look, here's a very simple module for how you can actually address some of the conditions you're seeing. And all of a sudden it's like, oh, it's not easy. And it's like, it's always been that easy, but there's always been this hesitance. So I think at least in the two districts that we have done, I think this year was really an opportune moment because a lot of people were really appreciative of gaining the skills, and you see that enthusiasm. They're very, very excited about it. It feels like something new. I don't know if they've been doing HIV for so long, but this kind of feels like something new for them, right? We have a WhatsApp group for communication with the facilities, and you see the way they ask questions, like the way they're like, "Oh, I'm reading this page. I don't understand this thing." That level of engagement at least is there for them. They're doing the things we ask them to do. It's not all the facilities, but at least the majority of them are very, very appreciative of the skills that we were able to capacitate them on. You still get a little bit of pushback in some of the others that are just kind of like, oh, I think I need to refer this to a specialist. And that's kind of like what we're trying to work on, like nudging them very, very slowly that, look, this is something you can do, and your patients will be very appreciative if you start providing them this sort of services.
Right.
I think it's sort of like there, but generally I would say they're very, very, very accommodating.
Right.
It's actually quite surprised us as well.
Yeah, well, no, that's great. I suppose the staff that you have been working with that are part of the program, I suppose they understand that if they can deal with the depression side of things, for example, they can also assist the patient to come to terms with the HIV/AIDS side of things. Is that how you see it, Esther?
Yes, that's correct. But as I indicated earlier, that if you have a mental health program, you might be having a problem in terms of adherence to your medication, right? So as a healthcare worker, when seeing that is able to help this patient if they have mental health issues, then they can be fine. Then it means they will adhere to their HIV care and treatment. So for them, I think what Ref is communicating, like, we see that they're able to connect the two and think that if they're able to address this, then automatically, or it will also be easier to address these other challenges that they are facing. Because as we have been saying, like they didn't have that, if I may call it, technical capacity. They didn't have these tools. They haven't been trained. But realizing is as simple as that, then okay, we can be able to address this. And at the end of the day, we will be able to support people living with HIV in Lesotho. Yeah.
Right. Ref,
Yes.
obviously, you made a reference earlier to medical provision, for example. And what about talking therapies? Have they become part of the program in at least the 2 districts where you are? For example, bringing people together and having discussions with a facilitator or something of that nature. Has that played a part, or is it not yet part of the program?
So I think the country, as part of when the guidelines were being developed for psychotherapy for the general population, the recommended one was Problem Management Plus. As you know, we are adopting quite a lot of the WHO guidelines. So Problem Management Plus, you can either do it individually or as a group. So thankfully, we have trained the healthcare workers on Problem Management Plus. And so we know some facilities have already started providing it for their patients. And some are kind of still feeling that sort of, oh, I'm not sure about this. So this is why the regular monitoring and supervision has been kind of important, because it's saying, well, look, you can do this. Let's sort of practice now with the people that we have and then see how we can work on it. But I think talking therapy is largely for, well, at least the way the guidelines have spoken now, is going to be for people that are for ANC in maternal healthcare. Yeah.
Okay. So, and are you able to measure the impact on the patients themselves? Because that, of course, is the whole point of this. And give me a kind of sense of what's being reported so far. We accept, of course, in asking the question, I accept that the program is still quite new. So, there's still going to be quite a lot of miles to put under the road before we can get to to a final assessment of impact, even in the 2 districts. But give me a sense of what's happening.
So we did do a preliminary prevalence assessment, which we screened 660 plus patients in those 2 districts that are living with HIV. And so at least we did see, in terms of like moderate to severe, which are the cases that we had for further management and treatment, those are the ones that we saw. And I think for depression, it was about 20%, right, of the patients that were showing or experiencing moderate to greater levels of those common mental health disorders, of that 660. And obviously some of them also expressed suicidal ideation. For those that were expressing suicidal ideation, then we were able to refer them directly to the MOTU, the Mental Health Observation Treatment Units, which Dr. Nesta talked about, and then they're able to follow up with them there. But because at that time the program was quite new, we didn't really follow up with what happened subsequently once we made that referral. But our understanding is because it's qualified psychiatric nurses, they are able to kind of help and assist those patients that we referred there. Similarly, for patients that were found with just moderate to moderately severe symptoms of those common mental health disorders, now they're able to kind of like follow up. And right now, for most of them, they're not on treatment. They're not on pharmacological treatment. They're more on psychosocial therapy type of thing, just discussion, talking to somebody and seeing how they can address some of their concerns, because a lot of the reasons that people are coming up are more dealing with community conflict, those type of areas, those type of reasons or factors that are affecting their mental health. And that's something that perhaps when you talk to somebody, at least you would feel a little bit better. And then you can do it more frequently. So that's what we know that they've been able to do. And then obviously, once the healthcare workers felt they are more competent now, starting, I think, December, late November, beginning of December, now they're able to screen more and more patients. They've even sometimes even extended to the general population. By now, I think it's been reported more than 1,000 people have been screened. And I think most of them are being managed at the facility level. There hasn't been a referral to the tertiary specialist center here in Lesotho.
Right. Thank you for that. Esther, one of the important features of CHAI, as you've already mentioned several times, has been the fact that government is your main partner. How do you think the government is going to react to or appreciate the idea of working in mental health more broadly, not just in the 2 districts where this particular program is taking place, but more broadly across the 10 districts of Lesotho. How do you think they'll react to that? Is it something they would like to do? Is it something that they're trying to do alongside you? What's your observation on that?
Um, Definitely, the government is really interested because there wasn't much that was happening as far as the mental health programming is concerned. It was more of people are transferred to the tertiary institution, especially, and then that's it. It was more of treating. But now also looking at, yes, we can be able to decentralize the services, and these services, they can be managed by non-specialists. The Ministry of Health has really seen the impact of this intervention. And as I had mentioned earlier, that we work with the government. So from the onset of programming and putting together this program, we discussed with the government. So we have been working hand in hand with them from the beginning in terms of shaping up the program, in terms of whatever Ref talked about. We are working with the Ministry of Health in every single step. So for them now, is they're looking at how do we expand to these other districts? So they have discussed about how can they increase the budget, which we are not so sure for if it will be doable in terms of the allocation for the mental health services. In fact, they have just approved the mental health policy. There is a plan to develop the implementation plan and all that. So the government is really enthusiastic in terms of how do we expand this. They have asked us to work with them hand in hand to mobilize resources because it requires resources to expand to those other districts. And how can we continue to support them? And definitely to require more resources. So with them now, we are in that phase, though we are implementing in those two districts, we are also mobilizing resources to ensure that how can we help the government to expand into other, because they have seen it's important, it's needed, and it's doable.
Right. And it's best done at community level rather than trying to refer everything to the tertiary level. Yeah.
Exactly. Yeah. Where there's only one specialist.
Sure.
Yeah.
Sure. Exactly. So Esther and Ref, thank you so much for a fascinating insight into the work that you're doing in Lesotho. Very much appreciated. It's really good to hear about chai as well and to understand more about that and to see the relationship between the HIV/AIDS programming that you obviously are well reputed for and this new approach to mental health and HIV/AIDS, which of course is really eye-opening and interesting. And what I have come to learn about as well, which is the relationship between starting a program which had the focus of patients with HIV/AIDS, and then recognizing that there was a wider program or goal to achieve in the field of mental health, and then hearing about how the government is beginning to respond to that. So very much appreciated, and thank you so much for being with us on the podcast today.
Thank you very much, Chris. We really appreciate. We are happy and being given this opportunity to speak about the program that we are implementing. And as we have indicated, we are still at the initial phases, but then we are mobilizing resources because we see that there is a need to expand to the remaining district. And as we have indicated, Lesotho is small with 2 million people, only 10 districts. So how can we mobilize more resources to get into the remaining 8 districts? Absolutely. And also, as Ref mentioned that, okay, the HIV was an entry point, but as we are implementing, we see that there's a need to expand to the general population. So it means in that case, we are also cracking our heads and mobilizing resources to see how we can expand to other population as well. So thank you very much, Chris, for giving us this opportunity. Yes.
Ref, thank you. I hope she's not cracking your head.
No. But she said it exactly the way I would have said it. We're very appreciative, but we want to see this program grow so that we're able to provide this sort of services for everybody else, for every Lesotho in the country.
Great. Okay, friends, thank you so much. And we'll be in touch. All the best.
Thank you, Chris.
Thank you very much, Chris.
Been a pleasure. All the best.